create two buckets where we could place all of the 11 HHS agencies under. We have a bucket that we would call a population focused, and the other bucket would be function focused. So for example, CDC, FDA would be a function. So FDA does medical device regulation and approval, and as well as medicine approval. That's a function. You look at CMS, that's also a function because they are focusing on bringing a particular product to the nation. Then you have agencies like the Administration for Children and Families, who focused on children and families. So that's a population. The Administration for Community Living, which focuses on the elderly population. Again, that focuses on that bucket of population. SAMHSA does not fall in either one of those two buckets. We are essentially an agency that focuses on the conditions of mental health and substance abuse. And our mission is to reduce the impact of substance abuse and mental illness on America's communities. We do this by helping states, territories, tribal nations, states, cities, municipalities, and counties act on the knowledge that behavioral health is essential to health, that prevention works, that treatment is effective, and people do recover. SAMHSA, as the lead public health agency, aims to improve and advance the behavioral health of the nation. One of the key ways in which I get to do this, and I'm again honored to have done this now for the past 8 years, is I get the opportunity to make sure that behavioral health is a topic of all other policy conversations, both at the state level, but also at the regional level and at the national level. And we do this by providing leadership and voice on behavioral health issues. We have the largest data and surveillance information, which I'll be sharing more of it later on in this presentation. We focus a lot on prevention and public education and dissemination of information. And if you are not on any of my list groups that you receive information from me, please, I would love to get your contact information, and you'll have mine at the end of this presentation. And I encourage you to send me your contact information if you would like to be added to our list group. All I ask is that you tell me what state you're in and what kind of information. Is it mental health, substance abuse, recovery support services, grant and funding announcements. We are also the regulations and standards setting. So we tabulate, and we also set the standards for our measurement and toxicology screenings. And we also set the practice improvements. So we work to bring the most recent knowledge and awareness of best practices to the provider community as well. And so we connect that. And then finally, we are obviously a funding agency as well. Next slide, please. When we look at these numbers, I am sharing this slide. The numbers that are not highlighted were numbers that I received on Monday, January 1st, when I submitted this PowerPoint to the organizers. But frankly, between Monday and today, the numbers have changed, and you can see the drastic changes. Globally, we are from 5.6 million to 6.2 million numbers of cases that are COVID related. In terms of numbers of deaths, we went from 335,000 to 376,000. So we still seeing an increase. In the United States, we're also seeing overall across the country, we are seeing a steady increase in the numbers. Again, from 1.7 million to 1.8 million of cases. In terms of deaths, the deaths are still rising, unfortunately. And the numbers are from 103,000 to 105 or 106,000. But then you can see the states that I cover, that I oversee. For those of you in New Jersey, we are now at 162,068 new cases. cases in the state, and we have gone to just under 12,000 deaths in New Jersey, unfortunately. New York, we went up to 374,000. And in terms of the cases, and in terms of deaths, we've increased to 30,000. New York City, the cases have increased, continue to increase, but at a much slower rate, which is incredible considering the size of the city of New York. Just to put things in perspective, New York City is the largest city in the country. We are number one, with just under 10 million people. And considering that size of a population, densely populated area, our cases have slowed down tremendously, frankly, because of the great work that all of you and in collaboration with the state, we've been able to, and the city, we've been able to stay afloat. Unfortunately, for Puerto Rico and the U.S. Virgin Islands, the numbers have, for Puerto Rico in particular, the numbers have increased, both in cases to 4,500, and our deaths have increased from 136 to 140 from Monday. The Virgin Islands is the one territory that has remained stable since Monday. So that's a good sign, but we need to continue to see the numbers drop. Next slide, please. This is a quick slide that shows the number of new cases per 100,000 in the past 2 weeks. And this was a snapshot of the week of May 10th through May 24th of this past month. And you can see that both for New York, and in particular New York City and New Jersey, the numbers have started to slow in terms of progression. So we are between moderate to moderate high rates of cases. And that's a really good sign. Puerto Rico remained at a moderate high, as well as the Virgin Islands was at a steady number. But our concern has always been New York City metro area and New Jersey, northern New Jersey in particular, because of the densely populated areas. And this disease is a great communicator, and it's communicable because of the densely populations, as opposed to other parts of the nation. Next slide, please. Here we see the downward trajectories for the nation and the states as of May 23rd. If you look at the map on the left-hand side of your screen, we're taking a snapshot of the week of May 16th, and you can see that New York and New Jersey, where they are in terms of the current downward trajectories. And if you look on the right-hand side, you see that both New York and New Jersey have made considerable changes in a downward trajectory of number of cases of COVID-19. So we are doing quite well in the Northeast area, better than pretty much the rest of the nation. Next slide, please. So although we think of COVID-19 as not necessarily having a direct impact on behavioral health, it is because of the situational directives that have raised the stakes relative to behavioral health. So we all received stay-at-home orders and social distancing, but those two aspects of reducing the spread of the disease has increased and has had many serious repercussions. Among them, we've had to learn, for those of us who are blessed to work from home, to learn how to do that. For many of us, we've never done that before. And for our students and for our children who've had to, out of the blue, start virtual learning sessions. I know in my home, it's been a challenge. And for many of us, the fear of what cannot be seen, and what does that mean for us, the fear of the unknown. But but there have been some very real outcomes of the social distancing and stay-at-home orders. The lack or loss of job, with the school closures, the disruption of services, disruption of normal routines, they have all elevated and escalated some of the mental health and substance abuse conditions. We know for a fact that our disaster distress and other helplines that we manage at a national level and at the covering state levels as well, we have seen over a 900% increase in those numbers of callers. We have also seen an increase with those who suffer from mental illness and substance abuse. But I think we need to pay attention to some of the reactions to these situational directives that we've been working under. We've seen an increase in anxiety, an increase in depression. We've also seen an increase in domestic violence. We've seen an increase in substance abuse. We've also, unfortunately, seen a spike in suicide and drug overdoses, in particular heroin, opioids. The challenge of grieving and the loss of loved ones and not being able to grieve in a meaningful way because of social distancing, all have contributed to our mental health and our mental wellness. But there's another aspect to COVID-19 that has impacted our communities. And I have to tell you that we are not talking too much about this, and we need to. The behavioral health provider community, there is tremendous staff fatigue, needing to help others while also trying to help themselves and help their own loved ones. That staff fatigue is something that is very real and requires support, nurturing, and being mindful of how far you can stretch yourself. There are folks who are experiencing PTSD as a result of the trauma of COVID-19. There's also been isolation and sense of loneliness related to this disease that we've been under. But what I do not hear is the impact on the moral injury of our providers in particular. That is something that I think we need to pay attention. Just very quickly, just so you understand what I mean by moral injury. When we think of PTSD, post-traumatic stress disorder, we think of it's a fear-based reaction to specific trauma, loud noises from a gunfire, from the battlefield, or from witnessing a horrific accident. But then there's moral injury, which is essentially the result of an injury to an individual's moral compass or moral consciousness that impacts the values and results in an act of perceived moral transgression. There can be profound emotional guilt and shame. The best case example are those providers, and I'm focusing on providers for a reason, but those providers who feel and recognize the need to help others and not being able to do so, or too tired to help. And many of us can get so caught up in the need to help others that we stop caring for our own selves. And then the guilt that we're not doing enough, that we could be doing better. That's moral injury. And it requires self-awareness and counseling to help us learn how to forgive ourselves for not being able to help others as much as we wanted to. This, I think, is one of the areas that we do not pay a lot of attention to, that needs a lot more attention. I think that this experience of being under COVID-19 has really raised the awareness of the mental health and the behavioral health needs of our nation and in our cities. But I hope that this also raises the awareness of recognizing that our counselors, our clinicians, our therapists, our social workers, they are also in need of support from the community as well. I am happy to say that our Assistant Secretary for Mental Health and Substance Abuse put out a specific report and letter to the nation, acknowledging that behavioral health providers are also essential workers and need to be treated with the same rights and privileges as we do other essential workers. Which is, to me specifically, having been in the field for many years now, it's another step forward in the recognition that behavioral health is essential to health. It's another step forward in recognizing that those who engage and commit to the field of substance abuse, mental health, recovery support services are seen of having of that same value. So I hope that you will look at that letter, and I'll provide some more information in a little while. Next slide, please. So when we look at our agency, we have developed a strategy to help address the opioid, the COVID-19 crisis by creating a national plan. And our plan consists of three legs of a stool, essentially. And the first one focuses on the public and looking at ensuring that we are providing general information and fact sheets, ensuring that we are engaging our states with FEMA in our crisis counseling program for those states who have requested additional psychological support services. We make sure that our disaster, distress, and suicide lines are open and available, and ensuring that we're sending the right messages across the states. The second leg of the stool, we have to focus on people with behavioral health conditions. We know, for example, that people who currently have a behavioral health condition, that COVID-19 is going to exacerbate those conditions if they are not in active treatment or connected to some level of support. So we need to pay attention to people with behavioral health conditions. And to facilitate that, both SAMHSA, CMS have made tremendous efforts to relax many of our rules, regulations, so that we could expand telehealth services and allow more codes to be added to Medicaid billable services under these privacy rules that have been relaxed. We've also done a lot of work in the area of MAT to create allowances and make it more easier for people to get their medications. And so focusing on the public, focusing on people with behavioral health conditions, and then we have to also focus on our workforce. So we made sure that our technology transfer centers, our centers that provide technical assistance to our provider community are available and accessible. So here in Region 2, I am grateful to say that we have both an addiction, a mental health, and a prevention technology transfer center here in Region 2 that's been supporting and providing support to various providers and organizations across the region. For more information about resources that's available through SAMHSA, you can go to samhsa.gov/coronavirus for more information. Next slide, please. So as you know, during the last CARES Act, Congress allowed $425 million were authorized to SAMHSA to help address the behavioral health in response to COVID-19. And essentially what we did here was to divide that into several buckets. So we did 110 million went to the states across the country, essentially 2 million per state, to shore up behavioral health services to the states in addressing COVID-19 related behavioral health conditions. We put out $40 million on top of the annual budget that we provide for suicide prevention and suicide helpline services. We added an additional 10 million specifically to our disaster and national helplines. We added 15 million for tribal nations to address COVID-19. And we did 250 million to address the certified community behavioral health programs, which both New York City, New York State, and in New Jersey, we have a large number of those programs, which is essentially to integrate, to better integrate mental health and substance abuse services within a healthcare setting. And we've increased our capacity to data collecting so that we can make better data decisions, better decisions to help address the behavioral health of the nation. Next slide, please. So if you go to our website, SAMHSA.gov, as it says on top of this slide, our homepage will look like this. And you will see under current topics, you'll see COVID-19 guidance and resources. Right now, we've added another app next to the COVID-19 that looks at just funding alone. We were hosting both funding and resources on the same webpage, but then we decided to make it easier for providers by separating the funding from all of the resources. Next slide. And if you click on this slide, you'll get to our coronavirus website. Thank you. And this is what the page looks like. So I encourage you all to visit our website. You will find information on grant announcements. We've done a specific letter to the provider field, as I said earlier, recognizing behavioral health providers as essential workers and other resources as well. So I encourage you to visit our site. Next slide, please. And these are the kinds of resources that you will find in there. For example, taking care of your behavioral health during quarantine and isolation times. You'll get fact sheets and information about intimate partner violence and child abuse considerations during COVID-19. As I said earlier, we've seen the rise in certain conditions as a result to COVID-19. And please feel free to access these and other resources at SAMHSA. I have a few more slides here that focus on resources, so I'm going to go very fast only because of time, but I encourage you to look at all of our additional information. I may have a comment here or there on the resources, but let's see. Next slide, please. So here is a quick virtual sample of resources that's available for those who are in recovery. Many folks have across the nation have been complaining to us that not having a support system, whether it's an AA, NA, CA meetings or other support networks. We worked with many organizations across the country to create and establish, in some cases, virtual platforms where people can go and connect and support one another for those who are in recovery. So I encourage you to look at this slide, and there's more behind through these links. Next slide, please. As I said earlier, we're focusing quite a bit on our workforce and our behavioral health workforce. And so we have both COVID-19 specific federal resources that's available to the general public and to our providers. We have the Addiction Technology Transfer Centers, which focus particularly on those providers who work in the addiction field. We have resources for leaders of organizations, nonprofit, for-profit, behavioral health organizations. We have resources for clinicians, for families, for tribal communities, and for resources for first responders. Again, all this is available through our national technology transfer centers. Next slide, please. Here's examples of some additional resources that we have available. Obviously, opioid is an area that we need to continue to focus. Serious mental illness is another area of focus. And also look, it's very important during these times to understand where does HIPAA and confidentiality fit in under a COVA environment. And so we've done quite a bit to spell that out and make sure that people understand the flexibilities that exist under these circumstances. Next slide. Many of our TA centers have also provided webinars, and these webinars are archived. So on telehealth billing, telehealth tools, and other telehealth related issues are all available through these links at the bottom of the slide. Next slide, please. But it's important that even though we're focusing on COVID-19 and its impact on behavioral health, we cannot stop and think that opioid and drug addiction is no longer an issue. The reality is that we've never had an opioid epidemic. What we have and continue to have is an addiction crisis that is in the form of an opioid epidemic right now. And it's the addiction crisis that we need to pay attention and keep our eyes on that ball. The reality is that not only do we have people with substance use disorders and people with mental illness, but we also have a considerable number of people who have both a mental health and a substance abuse, or what we sometimes like to call this co-occurring disorders. And we need to pay attention to those issues because these are the areas that we need to be mindful because of the added stress of COVID-19. Next slide, please. So Pandora's box. As you know, CMS and others, and SAMHSA included, we've created many regulatory flexibilities. We've increased the 1135 waivers, which allows for telehealth services for all variety, including mental health and substance abuse, to be offered online. We know that CMS has, as I said earlier, has increased their telehealth rules and rates and codes. And we've seen many changes in our service delivery system. And I'm sure that there are many people across the country who are saying, well, I hope these rules stay. The reality is that some of these rules will be pulled back. We'll sort of pull back the rope that we've given. But in some cases, I think that the Pandora's box has been open. And I think that telehealth is something that we will see growing in years to come. But the reality, like Pandora's box, the reality is that not everything is a panacea for both consumers or providers, frankly. Right now, we know that in rural parts of New York State and in some parts of New Jersey, the lack of broadband and internet access is a challenge. The reality is that there are many homes that do not have access to internet services, or let alone the equipment, a computer or an iPad to be able to engage with folks. So there are a number of shortcomings. And so we need to be mindful of that, and we need to look at ways to address some of these issues for the long term. I am happy to say that I am involved in a number of strategic conversations to look at how do we better help shore up those parts of the country, those parts of the region that need a better access, better broadband access during emergencies. And frankly, in order to have better services, clinical services, because not everyone can make it to an appointment at a external facility. Next slide, please. And so I'd like to leave you with some takeaways. I really believe in this. I think we are all, as a community, we're all strong, and we need to remember that we're strong, we're resilient, and we will persevere. In fact, we are persevering. But we got to do this together, because together as individuals, families, and communities, we need to take this and face this threat head on. I know that we can control this. I know that we can take action. And we're seeing that happen. We've seen people not through the social and civil disobedience that we're seeing, and unrest that we're seeing across the nation. It's not because we're helpless, but it's because we are in control that we are voicing our opinions. And I think that it's the right actions to take. And I want you to know that we have to remain optimistic and hopeful for the future. This public health threat will pass. We'll have more, but this one will pass. And not knowing all the facts, not knowing the real information, and being misguided or be given misinformation is not it's not helpful in the long run. So it's important to stay socially connected, but don't be physically connected right now. We just can't do that. I think it's really important for us to be mindful of. I'm going to stop here and allow my colleague partner here to present on her area. But I leave you here with some more information on our resources. If we could skim to the second to last slide, I think is my contact information. This is more resources, additional resources you can access later. But I think please feel free to reach out to me if I can be of any help. I would love to hear from all of you. Love to learn how you are coping with your through this crisis and what is working for you. Love to learn. I'm always interested in knowing how people manage during crises. And in this region, we've had our share of crisis for sure. So thank you very much, everyone.
Yes, thank you so much, Dennis Romero. I want to make sure that we're mindful that we have until 3:30, and I want to make sure that our guest, along with you, Monique, Tula, has an opportunity to share their presentation, and hopefully we can have some time for questions. Thank you so much, Dennis Romero. Monique, the mic is yours.
Okay, there we go. Thank you. Well, thank you so much for having me here today. I'm coming to you from Los Angeles, California, a little bit earlier here. Just a little bit about our organization. We were founded, Harm Reduction Coalition was founded about 26 years ago by a group of really visionary people who made the bold decision to care about and advocate for people who use drugs who were dying from AIDS at the time. Since then, we have grown to become a national organization. We have 2 brick and mortar offices occupied by no one right now in New York and Oakland. And we have a strong network of harm reduction advocates across the country. I'm actually going to go off topic a little bit, and I really don't need the slides. But if you could just forward 2 slides, I believe, to the black and white image of the North Star statement. There you go. And we can just leave it here for the duration of my talk. So a couple of years ago, I've been with this organization as the executive director for going on 4 years. And a couple of years ago, we launched our new North Star statement, which is Harm Reduction Coalition creates spaces for dialogue and action that help heal the harms of racialized drug policies. So there's 3 components to this statement. The first is a mandate to create space for dialogue and then act. This compels our organization to play a new role as convener, facilitator, coalition builder in a way that moves us beyond our traditional core activities, which when we began focused on HIV and hepatitis, viral hepatitis transmission. The second mandate is to help heal the harms, and that makes it more explicit. There's a broader vision of harm reduction that extends beyond prevention and risk reduction and toward reparative strategies that address trauma and social division and injustice. And then the last piece is that we name racialized drug policies as the nexus of damage and threat to all people, beyond people who use drugs, but all people, because drug policy in this country has never been race neutral, right? So from its origins, drug policies targeted immigrants and people of color, and the recent turn toward public health, more compassionate public health strategies for white folks who are caught up in the opioid crisis is a bit of a departure from the way we have historically worked to resolve addiction. Our shifting responses to drugs and people who use drugs have always been intertwined with race. But before I move on, I want to make sure that we acknowledge the moment that we're in. You know, it's important to consider the intersections of COVID-19, substance use, mental health, and harm reduction. But our country is literally on fire, and quite possibly could be on the brink of true transformation since the first time since the civil rights movement, which begat the feminist movement, the gay rights movement, and eventually the HIV movement, and then on towards the harm reduction movement. So my organization believes that harm reduction is about shifting power and resources. And I'll get into that in a little bit, but we can't have that conversation without recognizing the fact that there has not been a transference of wealth from white people to Black and brown people. We cannot have this conversation without naming white people's stranglehold on the criminal justice system, which quite visually played out in the way that George Floyd was murdered by a white police officer. White people create the laws that we live under. They train armies, mostly comprised of working and poverty class Black, brown, and white people, to enforce laws that target our own sisters and brothers. They build modern day plantations to imprison Black, brown, and poor people, treat them like chattel, and commodify our bodies. So white people hold positions of power that create the conditions that allow vulnerable people to be pushed towards society's bulging margins and keep them there until they die. And they do this to maintain their privilege and wealth as if it were, their birthright and theirs alone. So the emergence of the harm reduction movement was in direct response to the lack of attention and political will to address HIV/AIDS epidemic that was raging through the community of people who use drugs in the 80s and 90s. We know that people who have substance use disorders often have long histories of unmitigated trauma and mental illness that is compounded by inequitable access to the same treatment and support that their white counterparts. That was something that really struck me in the description of this session, because it speaks to something that we talk about every day. And I think that COVID-19 exposes the structural issues that keep us in these, in the margins that I talked about before. People who use drugs who don't have stable housing, trans folks who use, Black and brown gay men who use are especially vulnerable to acquiring HIV and viral hepatitis, other infectious diseases, as they cycle in and out of emergency rooms if they don't have adequate connection to healthcare or insurance, as well as corrections, as we've noted. So harm reduction has evolved into a modality for engaging with people who use drugs in a way that allows us to restore hope and personal autonomy and healing. The principles of harm reduction is really a set of practical strategies and ideas that are aimed at reducing the negative consequences that are sometimes associated with drug use. We know that not all drug use is bad or ends up being chaotic. And as I mentioned earlier, my organization believes that harm reduction is more than a public health strategy. It is a movement that is dedicated to shifting power and resources to people and communities that are most vulnerable to structural violence. Harm reduction is not the opposite of abstinence. It is an important part of the spectrum of interventions. For example, substance use treatment providers, even those who are focused on abstinence-based modalities, can use harm reduction tools, can add harm reduction tools to their existing toolkits. A little bit about syringe service programs and how they are responding to COVID-19. So syringe service programs are considered essential services, although that's not always recognized by some jurisdictions. In fact, in a recent survey that was a collaboration between the CDC, the North American Syringe Exchange Network, NYU, and the University of Washington, they wanted to get a better sense of the impact of COVID-19 on syringe service programs across the US. And nearly all of the respondents noted that policymakers and leaders were not including syringe service programs in their jurisdictional emergency planning and response. Despite that erasure, right, of people who use drugs, demand for harm reduction services is still high, right? COVID-19 does not equal people automatically changing their behavior, right? And in terms of using drugs or using other coping mechanisms just to get through the day. And so in response, staff of syringe service programs that have managed to remain open, they're prioritizing syringe and naloxone distribution over HIV and hepatitis, Hep C testing, which could put their funding in jeopardy. These programs are adapting to minimize, or rather maximize staff and participant safety by reinforcing social distancing, limiting the number of times people can come, increasing the quantity of supplies that is given in a single incident. And then in terms of people who are seeking treatment, we have gathered, along with some other folks, some materials for people who use drugs and providers on how to increase MAT. And Dennis mentioned earlier telehealth, and that's one way people are gaining access to buprenorphine. And methadone guidelines have changed at least twice since shelter in place. But clinics in states that have declared state of emergency, as well as those who can't, can now authorize 28 days of take-homes for patients who have been on a consistent dose, and they don't have to show signs of having COVID-19. And I would argue that these tactics should be used after shelter-in-place restrictions have been limited. If we can manage to change and pivot very quickly in a time of crisis, one would argue that we should be able to do it when we're not in crisis. So I'm going to pause there. I have a lot more that I could share, but I also know that the hosts want to make sure that there's an opportunity for the audience to ask questions.
Thank you so much, Monique, Tula. We actually let the audience know that because we ran a little over with the first presenter, we want to make sure that you had time, that we will have the opportunity to run a little over from 3:30. So it's up to you if you want to talk a little bit more or share some more slides, or we can go into questions, and just to be equitable, I'll pose them first to you.
Oh, sure. I guess I would want to, I believe that, you know, we're all suffering from collective trauma, and Dennis kind of touched on this earlier, right? I think it was moral injury that you spoke about, and this collective trauma is something that happens over generations and across communities. Collective trauma began with our ancestors, you know, and it continues unabated to the present moment. Collective trauma includes things like war and genocide and slavery, natural disasters, but it also includes pandemics like COVID and HIV, or the opioid overdose epidemic. You know, the survivor guilt that we experience as a result of collective trauma, you know, it's normal for us to experience that. It's normal for us to feel the rage or be, you know, the depression or even go into denial, you know, whatever the thing is that just kind of keeps us moving through the day, right? In response to COVID-19, the harm reduction community rallied very quickly, designing and distributing information. And that is because it is a modality that is centered around mutual aid. And we've been hearing a lot about mutual aid in the last couple of months. One of the things that we know is that, or believe, is that at the root of addiction is often pain. The root of addiction is often pain. And there's a British author that I follow. He put out a TED Talk back in 2015. His name is Johann Hari. And he, you know, according to Hari, the cause of addiction is the lack of human connection. So he says that human beings have a natural and innate need to bond. And when we're happy and healthy, we'll bond and connect with each other. But if you can't do that because you're traumatized or isolated, right, or beaten down by life, you will bond with something that will give you a sense of relief, because that is our nature. So I fully agree that we're going to continue to see an uptick in addiction, and correlated to COVID-19, and we need to prepare for that. So when I talk about mutual aid, there is a depth of experience and skill and knowledge that the group of people in this room right now, all of you, have, that we need to draw on, because our communities, our people are at risk. Our people, right? Black and brown people, we're the ones who are at the most risk. And, you know, we have biological and psychological characteristics that make us vulnerable or resilient. But we don't typically live in isolation. We're part of families, we're part of communities and society, you know. And I think that COVID-19 and the overdose crisis shares or exposes some of these underlying issues that have to be dealt with. Now is the time to act, not to wait. I'll leave it there.
Great, thank you so much to both of our presenters. So as I said earlier, we're going to run over a little later to be able to get to your questions and answers. And so I hope that you'll be able to stay with us. Originally, we were going to be until 3:30. We're going to stay until 3:45. And my first question, I'm actually going to open it up to you, Monique, Tula, and then we'll hear from Dennis Romero. This is a question that came from Rebecca, and Rebecca, my apologies if I say your last name incorrectly, Wiley. And the question is, and I think it's a really astute question for the time that we're in. Oops, I just lost my screen with the questions. My apologies. The question is really astute for the time that we're in right now and what you were just sharing, Monique, as well as a nice link to what Dennis was presenting earlier. And the question is, how can we take anti-racist action in both harm reduction services and mental health services? And I just do want to place an asterisk that anti-racist may not be a term that some of our audience members are familiar with. So if Monique, you'd like to provide a definition, I know that Rebecca also was willing to provide a definition. Monique, would you like to go first? Okay.
Yeah, thank you. You have to unmute me. So Rebecca, I encourage you to put your definition in the chat box, but we talk, in fact, the slides that I didn't use included anti-racism, integrating anti-racism into the framework, the anti-racism framework into what we're doing. It's really acknowledging the presence of institutional racism. It is basic as that. There is not one institution in this country that does not have where institutional racism is not embedded in it. If it was born on the soil of U.S. soil, it's there, it's present. So for us, when I talked earlier about shifting power and resources, I'm specifically talking about community mobilization, looking at wealth redistribution. I mentioned how there hasn't been, a significant transfer of wealth from white people to Black and brown people, knowledge transfer, and even comprehensive data tracking. And we need all of those pieces to be working in tandem so that local groups and individuals have the tools that they need to engage effectively in the local and national policy and advocacy. We need to make a serious commitment to double down on harm reduction programs across the country. We know that syringe service programs are the most effective way to reach people who use drugs, people who inject drugs in particular. And there's a number of regulations and barriers that prevents us from bringing syringe service programs to scale. COVID-19, HIV, viral hepatitis, overdose, also expose the same racial and class disparities that have long existed in the United States. And I'm going to say it if nobody else can say it. The Trump administration is really clear about who they value, and it's not us. So our job as social justice and public health advocates is to amplify the voices of people who are struggling in a society that is structured to deprive them of basic rights. And we can draw on some of the earlier successes, say, for example, of the HIV/AIDS movement, and use COVID-19 as a catalyst for shifting power, working with our leaders to create the policies that we need to lift people out of or push them back, away from the margins and back into the center.
Thank you so much for that, Monique. Dennis, would you like to share your thoughts on the question? How can we take anti-racist action in both harm reduction services and mental health services?
First of all, I am so impressed to hear Monique provide her overview. We as human beings, we desperately desire to be heard. We also desperately desire to be connected to others. And so when we don't have that, we experience psychological injuries. And some of these wounds, unfortunately, are multi-generational. And needing to connect oneself to like-minded people is essential to good health. I really can't comment other than to encourage everyone to exercise your civil liberties. We are all we're all in some very, very challenging times. But if we look across the nation, many of the local leaders that are out there, they're young people. They're younger than me, certainly. And I see that as the hope for the future. I just encourage everyone not to feel like you're alone or misunderstood. That to me is, I think the worst damage we can do to anyone is ignore them, make them feel that they're not part of our community, the human race. Everybody needs to be loved. Everybody needs to be considered part of someone else. I think Monique said it very well.
Excellent. Thank you so much. So we have a few more questions. This is from Sofia Moyano Kleckner. Again, my apologies if I pronounced names incorrectly. The question is, and again, I'm going to open this up to Monique first and then pass it on to Dennis. Do you know of any information specifically about the rate of child abuse during this time? And what the current situation may have as far as an impact on parenting?
So I don't have that information. I'm happy to do a little digging. I can share. I have heard anecdotally that domestic violence is on the rise, along with child abuse. You know, the level of stress that people are experiencing, like it's unprecedented times, right? So I really wouldn't be surprised to see a spike in incidences of child abuse. It's also the thing that, like, I could never work in that realm, you know, of social work. It's the thing that really, it paralyzes me. I go right into amygdala hijack and can't even talk about it. So I'm curious, Dennis, if you have more information about that.
Well, unfortunately, we do have information, and there's been an increase. I don't know if we can very clearly make the connection between essential services, and one of them being liquor stores, and staying at home orders. But we have seen both partner violence increases because of the ER visits. And that's one way that our data comes from, is from ER visits. So we've seen an increase in domestic violence and partner violence. We've also seen a correlation between domestic violence and child abuse. Unfortunately, situations like COVID-19 really shine the spotlight on some of the real needs and challenges across our nation. We have a real need for helping people manage their worlds, their challenges. Suicide has also gone up. Interestingly enough, the number one form of suicide right now is self-suffocation. It's very sad. It saddens me to know that people will do that because they feel like there's no other choice. And that's why I say we need to give people hope. And we give hope to one another by staying connected to one another, by ensuring that no one stays alone, by calling friends or acquaintances just to check in. It's amazing what that does when we connect with others. But we also need to create the space and the room for people to talk, particularly our children. They need to understand. They need to understand from us why things are happening right now, why we have this perfect storm of both a national global pandemic, an opioid crisis, and civil unrest. And this does not even begin to talk about other challenges that we have, but we don't pay attention to, whether it's housing, the need to have shelter. You know, I've always said that housing is health. Without housing, it's hard to have good health. And I think as Monique talked about the linkage and the connections between social determinants of health and quality of life, we have to pay attention that poverty, education, housing, those are real markers on our social determinants. I would add that although we are challenged by these repercussions of COVID-19, child abuse, domestic violence, we have to remember that there is in our society and in our local societies, we have something that is of tremendous value that we don't harness, and that is our social capital. The local social capital, and that's something that I've been working on with several faith-based congregations across my region, to encourage them to realize that you have social capital, whether you're a nurse in the community, you're a doctor, you're a psychologist, you're a grocery owner. Maybe someone else wants to learn how to be their own grocery owners. When I was young, my mother would always say to me, if I want to be a psychologist, I have to find someone who is a psychologist and find out how they got there. What roads did they take? That applies to all of us. And we all, as adults, deserve to give back to our other members in our community. So reharnessing, recapturing the social capital of our communities, I think, is the one way to begin to address these real systemic issues that we have in our society as well.
My apologies, I keep forgetting to unmute. So thank you so much to Dennis for your response. Thank you so much, Monique, for your response as well. Thank you to both of you for sharing your thoughts, your presentations, the amazing work that both of your organizations do. I'm gonna end the meeting now. I do wanna let all participants know, 1, you will be receiving the slides. 2, you will have access to the recordings. Please, I'm the Director of Monitoring and Evaluation and Learning. Please fill out the evaluation link. This is the first year that we're doing Reunión Latina virtually, given the circumstance, but we also think this is an amazing way for folks that maybe have limited mobility and maybe are not necessarily able to travel for future years to have this virtually. So your evaluation, participation really matters. I encourage you to reach out to our speakers through us if you wanna learn more or have more questions about resources. And I did share with you all in the chat box that if you are interested in learning more about anti-racist theory and frameworks and you're not too familiar with it, there's an excellent book put out by the definer of the term. So with that, I am going to wish you all a blessed rest of your day. Thank you so much. Ciao.
Thank you.